Good.
मैम क्लास चालू की लाइव है।
Hello guys, welcome back. Please check my audio video if it is good to go. Guys, what time is your prayer timings for the iftar? What time is the iftar today? According to that, we can decide what time we can stop the class today. Can you comment on the audio video? Can you please comment on my audio and video? Are you there? Good, ma'am है. Audio video fine है. Shall we start with the treatment of the cataract? So we have to do treatment of choice is the surgery for the cataract. We all know this. Treatment of choice is the surgery, and what we are doing is the cataract extraction. We have to do the cataract extraction with the PCIOL implantation. What surgery we have to do? We have to do the cataract extraction with the PCIOL implantation. Cataract extraction with the PCIOL implantation. So for the cataract extraction, whenever you remove the lens, है ना, we will create aphakia. And when you give this artificial lens, this is called as pseudophakia. So two new terms you have to understand. One is aphakia, means we will have absence of the lens, and then we have to replace it with the artificial lens. This is called as pseudophakia. The surgery is cataract extraction with the PCIOL implantation. When you extract the lens, when you remove the lens, we have aphakia, and when you give the artificial lens, it is pseudophakia. ये क्लियर है? Now what is PCIOL? This is posterior chamber intraocular lens. Posterior chamber intraocular lens. So where you are giving this intraocular lens? In posterior chamber. And in the posterior chamber, we give at the posterior capsule. This is the best site. Best site for the IUL. This is also your PYQ. Best site for the IUL implantation. Best site for the IUL implantation is the posterior capsule. तो पहले व्हाट इज एफेकिया, फिर है स्यूडोफेकिया, फिर योर पीसीआईयूएल. तो आर्टिफिशियल लेंस जो प्लेस करते हैं, वी आर प्लेसिंग इट ओवर द पोस्टीरियर कैप्सूल. दैट इज द बेस्ट साइट, बेस्ट प्लेस फॉर द आईयूएल इम्प्लांटेशन. ठीक है, ऑल गुड है. Now, what are the types of surgeries by which you can remove this lens? So, if I talk about the types of the surgeries, type of surgeries में, oh, just 2 seconds guys, we have ICCE. Now, what is the name of this? This is called as intracapsular cataract extraction. Intracapsular cataract extraction. Now, this is the oldest surgery that we are doing. Intra means including. This surgery is including the capsule, which is posterior capsule. So when we do the surgery, we also remove the posterior capsule. Now, can you understand? Posterior capsule was the best site for the IOL, and if I am doing a surgery where I am removing the posterior capsule, therefore it is obsolete now. Therefore, this surgery is obsolete. Now, we are not doing this surgery because here you are removing the best site for the IOL placement, best place for the IOL placement, that is the posterior capsule. If you look at the incision here is very, very large, 10 to 12 mm at the limbus. If you look at the incision, that is also very large, 10 to 12 mm. If you are giving a large incision, you have to give more sutures and therefore more complications. So this is also a reason why this surgery is obsolete, and now we are not doing this surgery, intracapsular cataract extraction. तो one by one चलेंगे. First write about intracapsular cataract extraction. First is intracapsular cataract extraction, and then second is ECCE. That we are doing nowadays is ECCE. ICCE लिखा सबने. Now the next is extracapsular cataract extraction. Extracapsular kind of cataract extraction है. Extra means excluding. This is excluding the posterior capsule. One is including the posterior capsule, one is excluding. अब यहाँ पर we are excluding the posterior capsule, you are leaving the posterior capsule over which you can place the IUL. So this is favored, and if you look at the incision, then this is 7 to 8 mm at the limbus. This incision is 7 to 8 mm at the limbus. So incision of ICCE is 10 to 12 at the limbus. ECCE में 7 to 8 mm है. Smaller than ICCE है, but still larger, and you have to give the sutures. So I will give even more small incisions. One is intracapsular, one is extracapsular. So one is including the posterior capsule, one is excluding the posterior capsule. Now we can do even the smaller than this, that is SICS. This will be the small incision Small incision cataract surgery. So another surgery that we can do is small incision cataract surgery, where we do ECCE via smaller incision. If you are doing same ECCE but even via a smaller incision 5 to 7 mm by the corneoscleral tunnel. This is also an important question. Where do you make a tunnel? So tunnel is made in SICS. 5 to 7 mm by corneoscleral tunnel at the limbus. This is also your PYQ, corneoscleral tunnel at the limbus. Corneoscleral tunnel at the limbus. While fourth will be the phacoemulsification. Next is the phacoemulsification. This is the most advanced technique, advanced surgery. The most advanced surgery that we do nowadays is phacoemulsification. This surgery is the sutureless surgery. This surgery is the sutureless surgery here. Here we are not giving any sutures. And how you are doing it? Suppose this is the limbus. Okay? This is the cornea and that is the limbus. So here we are giving the two incisions. One is this main incision and one is the side port. One is this main incision and one will be the side incision. This is called as side port. So main incision जो है, this is your 3 to 3.5 mm and side port is 1 to 2 mm. Now through this main incision we do the phacoemulsification is done by this main incision, and through the side port we will do the irrigation and aspiration. Irrigation and aspiration. Phacoemulsification, and here we are doing irrigation and aspiration. So one was your ICC, that was 10 to 12. Then ECC 7 to 8. Then SICS में 5 to 7 है. Then is the phacoemulsification, which is your sutureless surgery. We are giving very small incisions here. If you look at the blades, so phacoemulsification, main incision is given by a keratome blade. This kind of blade we have. The angle here is 45 degree. This is the keratome blade. And if you look at the side port irrigation and aspiration hai, we are giving this kind of, using this kind of blade here, where the angle is just 15 degree. This is called as side port blade. This is called as side port blade. So when there was your examination during the COVID times, August 2020 paper mein this was asked. August 2020 paper mein. In the August 2020 paper, this was asked. Please see if you have understood the differences and their sutures. Explain again. So, in cases of phacoemulsification, we are giving two incisions. One is this main incision and one is the small side port. Main incision से we do the surgery and through the side port we do irrigation and aspiration. Now what does this mean? I will take the phaco machine, phaco probe through this main incision. I will break the lens, and through the side port we will put the irrigating solution. Now the lens will go from this area and the irrigating solution will come from this area and it will dissolve. Now once this has been dissolved in the irrigating solution, we can aspirate. We can aspirate through this side port and the lens area will be clear. So from here we are doing the disintegration of lens, and from here we are doing the irrigation, and then you will take out the whole cortical matter. Irrigation and aspiration. अभी समझ में आया इमाद? What about the others? Have you understood? Can we go to number 5? We have one more surgery which is called as flex. Flex is your femtosecond laser assisted cataract surgery. femtosecond laser assisted cataract surgery है, where we are using this femtosecond laser. femtosecond laser है 1053 nanometer. This surgery is bladeless plus sutureless. This is bladeless as well as sutureless. So in this surgery, we are using the laser. Instead of any blade. That is why this is also called as bladeless surgery. Therefore, also called as bladeless surgery. ठीक है? Now we will use the IUL. How does a IUL look like? We will have two parts of the IUL. One is this and one will be the hooks, something like this. IUL will consist of two parts. One will be the optics and one will be the haptics. Optics will give me the refractive surface and haptics will give me the hooks for the IUL ka implantation. Every IUL will consist of two parts. Optics hai, that is giving the refractive surface, and these are the two hooks which are the haptics or the hooks by which we can implant our IUL over the posterior capsule. These are the parts of the IUL. Now, how to calculate the power of the IUL? If I want to calculate the power, we can use a machine called as biometer. And the formula is SRK formula. Power of the IUL is calculated by the biometer. This is one machine. Formula is SRK formula, which says P is equal to A minus 2.5 L minus 0.9 K. This is the total formula for the IUL, where P is the power, A is the IUL constant, then L is the axial length, and K will be the corneal curvature. This axial length is calculated by the A scan ultrasound, and corneal curvature by the keratometer. Corneal curvature is calculated by the keratometer. So I will show you the questions based on this. Those who have written, see the question and try to answer this. Quiz number 1148. See the quiz number 1148. Then 1144. So what are the things that you require? We require biometer, keratometer, A-scan and SRK formula. So what is not required will be the topography. Corneal topography is not required. Corneal topography. C will be the answer. This is how we calculate the power of the IUL. So the different kind of surgeries and the IUL power, how to calculate the power of the IUL. This we have done. Have you written this much? Then we have the types of the IUL. There are different kind of IULs हैं. One will be the rigid IULs, which are non-foldable. Rigid or non-foldable IULs. These are made up of PMMA, polymethoxymethaacrylate, polymethoxymethaacrylate will be used in the ICCE and the ECC when we are giving large incisions. In the large incision surgeries, I can use the non-foldable variety. If I cannot fold it, I will require a large incision. This is made up of PMMA. Then is the foldable. Foldable IUL is made up of the acrylic used in SICS, and third is the rollable. Rollable are the ultra thin IULs. Then we have the rollable. Rollable are the ultra thin IULs. They are made up of hydrogel, and it will be used in the phacoemulsification. This will be used in the phacoemulsification. This is used in phacoemulsification. So we have the non-foldable IUL, foldable IUL, rollable IUL, which are made up of PMMA, which is made up of acrylic as well as hydrogel. बहुत सारे MCQs are coming from this area. We have the different kinds of surgeries है, the power of the IOL है, then different machines which are used to calculate the different parts along with the different kinds of IOL. ठीक है? Are you getting? Are you able to write? लिख लिया है? Then we will move towards the complications. Complications of the surgery. Cataract surgery, like any other surgery, will have a number of complications which can be divided into intraoperative complications and post-operative. Previous slide. ये लो previous slide. फर्स्ट वाला भी नहीं लिखा तुमने? डार्क ब्लैक. रिजिड और द नॉन फोल्डेबल IOL है, मेड अप ऑफ PMMA, पॉलीमिथॉक्सी मिथा एक्राइलेट. बाकी सबने लिख लिया? ऑल ऑफ यू हैव रिटन दिस? Now coming towards the complication of surgery, we have intraoperative and post-operative. Post-operative में can be early post-operative as well as late post-operative. We have three kind of complications: intraoperative, early post-operative, late post-operative. Early post-operative will be less than 3 weeks. Late post-operative 3 or more than 3 weeks. 3 or more than 3 weeks. So now we have intraoperative, early post-operative, late post-operative. First we will see the intraoperative. In the intraoperative, number 1, we can have injury to the cornea. During the surgery, we can have injury to the cornea, especially the Descemet's membrane. Especially the Descemet's membrane, which is called as, this is called as Descemet membrane detachment. First, we can have injury to the cornea. Injury to the cornea में we can have the Descemet membrane detachment. This is the first intraoperative complications. Do you know how many layers we have in cornea? Cornea में we have got the 6 layers. 6 layers, and out of these 6 layers, the most important is your Descemet's membrane. No, Sindhu, now we have 6 layers of the cornea. Initially, we used to say that we have 5 layers in the cornea, but now we have one more layer which is invented. So now we have 6 layers, and out of this, most important is the Descemet's membrane. So it is the Descemet membrane detachment. Then number 2, we can also have injury to the iris. Injury to the iris. This is called as iridodylisis, leading to D-shaped pupil. Iridodylisis leading to the D-shaped pupil. This is also a PYQ. What is iridodylisis? That is the detachment. It is the detachment of the iris from its root. Detachment of the iris from its root is called as the iridodylisis. So, if I have the iris like this, and In the center we will have the pupil like this. Okay? So basically this area is the root of the iris, and this will be called as pupillary border. This is called as pupillary border. So when I have the detachment of the iris from its root, so here we are having this detachment. Due to this detachment, we will have the one more pupil here. This. This is the detachment, due to which we will have the one more pupil. This. This is iridodialysis, and due to this iridodialysis, the shape of the pupil will also become D-shaped like this. So we will have the D-shaped pupil like this. ये देखो, shape of the pupil will be D-like. This is called as iridodialysis with the D-shaped pupil. Whenever there is an injury to the iris, we can have the detachment of the iris from its root. So this is the detachment of the iris from its root. You can see this is the detachment of the iris from its root here, which will lead to D shape of the pupil. First two of the complications are clear, guys. One was your descendant membrane detachment, and second is iridodialysis with the D-shaped pupil. ठीक है, नंबर 3 पे चले. Number 3, we can have the expulsive choroidal hemorrhage. We can also have hemorrhage from the choriocapillaries, expulsive choroidal hemorrhage, especially if the patient is having hypertension or the heart disease. So if my patient is having hypertension or heart diseases, then you should not operate without the proper checkup. Always check the blood pressure, always check the ECG of the patient. If it is not normal, then you should not operate. While most severe intraoperative complication, most severe intraoperative is PCR, posterior capsular rupture. Most severe intracapsular is PCR, that is posterior capsular rupture. So for the 4 complications, if you have understood and if you have written, then give me a thumbs up. Chalo. One was your cornea injury. One was your iris injury. One was the choroid injury, and one is the injury to the posterior capsule. And posterior capsule pe we have to place the IOL. If it is ruptured, I cannot do PCIOL implantation. All 4 intraoperative you have done. सबने कर लिया. Then early post operative complications. 10 on 10 हो गया. वेरी गुड. तो अर्ली पोस्ट ऑपरेटिव में जो मोस्ट कॉमन है, दैट इज द हाइफीमा or the blood in the anterior chamber. Most common is hyphema or the blood in the anterior chamber. Then number 2, we can have the iris prolapse which is due to the high intraocular pressure. The first is the hyphema, that is the blood in anterior chamber. Then iris can come out. When the pressure is very high, it will push the iris out. Iris prolapse. And number 3, we can have corneal edema. Corneal edema. These are the 3 complications which can take place in the early post-operative period, less than 3 weeks of the surgery. Early post-operative complications में. And then we have late post-operative. In the late post-operative, most common is PCO. In the late post-operative PCO, posterior capsular opacification, posterior capsular opacification, where we will have diminution of vision after 1 year of the surgery. There will be diminution of vision after the 1 year of surgery, PCO. Now, posterior capsule over which you had placed the IOL is opacified, due to which again we have diminution of vision. These are of 2 types. One will be the Sommering's ring cataract. There are 2 types, Sommering ring cataract, and another is the Elshing's pearl cataract. Sommering's ring cataract and the Elshing's pearl cataract, and both will have same treatment. Both will give you same treatment, Nd:YAG, posterior capsulotomy. Nd:YAG posterior capsulotomy 1064 नैनोमीटर. ये बहुत ही इम्पोर्टेंट PYQ है, वेरी वेरी इम्पोर्टेंट. आफ्टर 1 year होता है. The name of the laser, wavelength of the laser, unit of the laser. Nd:YAG posterior capsulotomy. While if they ask you most severe complication overall they are asking you the most severe complication of the cataract surgery, then it is the bacterial endophthalmitis, then it is the bacterial endophthalmitis. Endo means inner. So it is involving the inner layers of the eyeball. It is involving the inner layers of the eyeball, sparing the sclera. This is involving the inner layers of the eyeball, sparing the sclera. The best prophylaxis for this will be the 5% povidone iodine. The best prophylaxis to prevent the bacterial endophthalmitis is 5% povidone iodine. This is povidone iodine. And if they ask you the etiology Then you have to see the early onset as well as the late onset. Early onset is caused by the staph epidermidis, while the late is caused by the Propionibacterium acnes. Propionibacterium acnes. Staph epidermidis है, Propionibacterium acnes, 5% povidone iodine. So I will show you the question also on this. See the quiz number 86. देखो, if you have written all the complications, you have understood intraoperative, early post-operative, late post-operative, how to calculate the power, the types of IULs. Then we can talk about the treatment of the congenital cataract. Treatment of congenital cataract में we can have unilateral cataract or we can have bilateral cataract. Now, if there is a unilateral cataract, you have to do surgery urgently. And if it is a bilateral, we have to do the surgery before the development of the fixation reflex. Here we have to do the surgery before the development of fixation reflex. Fixation reflex comes between 2 to 4 months. ठीक है? Therefore, you have to do between 4 to 6 weeks of the life. Do the surgery between 4 to 6 weeks. Now, fixation reflex starts at 2 months. 2 months is 8 weeks. Therefore, before that we have to start, because you cannot fix with one eye. You require both the eyes to fix. इसीलिए before the development of fixation reflex. इसके लिए कह रही हो ऋषि? Are you talking about this slide? Endophthalmitis? Guys, how many of you are fasting today? Anyone who is fasting today? And which subjects you have already done? Which subjects you people have already done, guys? So we will be revising those things if you have already done that part. If there is a unilateral cataract, then you have to do the surgery urgently or as soon as possible. You have to do Because we have more risk of, here we have to do more, we have more risk of amblyopia. Because here we have more risk of amblyopia. Majority here I can see only some of them, not even 50%, matlab all except ENT, Ophtha, Pharma and Medicine. उसमें से Ophtha is going on, so you will be left only with the ENT, Pharma and Medicine. So anatomy you have done, physio, biochem you have done, path you have done, forensic you have done, PSM का half is left. Only Pharma, Medicine, ENT, Derma. Ortho you have done, psychiatry, surgery also you have done. तब भी you people are radio, surgery, last two topic. Then why you are writing so slowly, guys? Vote karo. I have only 14 votes for fasting. How many of you are fasting? Most of them took the printout. But what do you feel is better? Printout? Are you able to understand from printout? Even if the PDFs are annotated, are you able to follow them? Yes, writing is best, I think. When you are writing yourself now, it's always better for you. Have you written now? We are trying to answer MCQ. Meanwhile, the slide, your writing goes up, ma'am. Acha. Now you have written? Hello? 9. When we come back after solving MCQs, you would reach somewhere. Now you have reached there or not? अभी लिख लिया है? You have reached somewhere. मैं तो यहीं पे हूँ. I am not reaching somewhere. Now the surgery which is done in children. This surgery is called as lensectomy with the anterior vitrectomy. The name of the surgery that we are doing in the congenital cataract is lensectomy with the anterior vitrectomy. Can you explain fluctuating refractive error? ये तो हमने directly किया था. Fluctuation of refractive error is found in diabetic cataract. Canal. This we have done directly. Fluctuation of refractive error is found in diabetic cataract. Yes or no? And the power of the IOL in children should be it should be under correction. In cases of children, we are doing under correction. No problem. Under correction, we are doing by 20%. If the age is less than 2 years. Under correction by 20% if the age is less than 2 years. Number 2, by 10% if the age is between 2 to 8 years, we are doing by 10%. And number 3, we can do full correction. Full correction we can do after the age of 8 years. Why we can do full correction after 8 years, guys? Small children के लिए we do under correction. So when you give less power, we are creating hypermetropia, and that was the normal refractive status also of the babies. Every newborn was hypermetropic at the time of birth. How much hypermetropia? +2 to +3. So we are creating the hypermetropia, and when the age is more than 8 years, the babies already are emetropic. By the age of 5 to 7 years, then we have to do the full correction. Then we can give the full correction. So once you have written, then you can tell me, then I will slide. Otherwise you will say I have reached somewhere. See if you have written. Okay, so now we come to the lens anomalies. लेंस एनोमली में फर्स्ट इज इक्टोपिया लेंटिस. इक्टोपिया लेंटिस है वेयर वी हैव द abnormal position of the lens. We have abnormal position of the lens associated with the congenital anomalies. If there is a abnormal position of the lens which is associated with the congenital anomalies, then this is called as ectopia lentis. So number 1, we can have Marfan syndrome. One is the Marfan syndrome where the subluxation is supratemporal. Supratemporal subluxation. Then number 2, we have homocystinuria. Homocystinuria में we have inferonasal subluxation. Inferonasal kind of subluxation. Then number 3, we have the Ehlers-Danlos syndrome. Ehlers-Danlos syndrome है where we get the subluxation along with the blue sclera. So here we do not have any specific direction of subluxation, but along with the subluxation we have blue sclera along with number 4, Weil-Marchesani syndrome, where we will get antero-inferior subluxation. Here we get antero-inferior kind of subluxation. So we can have Marfan syndrome, homocystinuria है, and you people have done all the subjects now. So can you tell me which enzyme deficiency is found in homocystinuria? Which enzyme deficiency is found in homocystinuria? Your biochemistry. Which enzyme deficiency is found in homocystinuria? It is the deficiency of the cystathione synthetase. Cystathione synthetase enzyme. Yes, which is acting. Cystathione नहीं है, cystathione synthetase, which acts on the methionine. This acts on the methionine. So when this enzyme will act on methionine, it will convert into homocysteine, and this homocysteine will be converted into cysteine. ठीक है, written ectopia lentis. Then another one is the lenticonus. Another is the lenticonus है, where you get the conical protrusion of the lens. It can be anterior lenticonus, it can be posterior lenticonus. Anterior lenticonus is found in the Alport syndrome. And posterior lenticonus is found in the Lowe's syndrome. So this completes the lens. Once you have written, tell me, then I will show you the images. तो आपने लिख लिया है? Everybody has written? ये देखो, the beautiful iridodialysis with the D-shaped pupil है. ये somebody has shared this picture. ये बहुत important है. It's PYQ image which has come in your exam. Today's class is till. So I will have to see how many people are fasting and what time is your fast opening. Imad, you have not written ectopia lentis. We have done the lenticonus also. After the images, I will get back to that area, okay? $640 is your then. So before that, I will leave you so that you can do the prayers and everything. Then you can see this one is the iris coming out. So this is the iris prolapse. So what you had been done, it is the iris prolapse. What is this, guys? This is the hyphema. You can see the blood in the anterior chamber. Hyphema or the blood in the anterior chamber. Most common early post-operative. Yes, very good. Most common early post-operative है ये. This is the ring-shaped cataract. Somerings. Ring cataract. Somerings ring cataract. This is the Somerings ring cataract. This is a kind of PCO, Somering's ring-shaped cataract, where you are having the ring-shape opacification in the lens. While this one is the Elshing's pearl. Elshing's pearl cataract. Here you can get the small pearl-like appearances. These are vacuolated cells. These are the vacuolated cells. Elshing's pearl cataract. These are the Elshing's pearl cataract vacuolated cells. Then you can see this. This is the cornea. And this one is the lens, where you can see this anterior convexity. So this anterior convexity is called as anterior lenticonus. Anterior lenticonus. This is a slit lamp image where you can see cornea and the lens along with the anterior lenticonus. And then you can see the posterior also. ये देखो. This one is the cornea. So this is the anterior surface of lens and this is the posterior lenticonus. And this is the posterior lenticonus. I will share the annotated PDF. I will share the annotated PDF. Then somebody was asking for the ectopia lentis. Please write down ectopia lentis. What was left, please see. Then if I talk about this, can you tell me this question 1180? Please see. Before answering this question, see the images that I have shared. How to see whether it is the supratemporal subluxation or it is inferonasal subluxation. You will have to check that. Is it supratemporal or is it inferonasal subluxation? Everybody is typing A. Please see the type of subluxation in Marfan syndrome supratemporal hai. But picture में they have given you inferonasal subluxation. So it is a case of homocystinuria, inferonasal subluxation, not the Marfan syndrome. Inferonasal subluxation is homocystinuria, guys. Yes. Same clinical features giving the inferonasal subluxation, then it is homocystinuria. Same clinical features, supratemporal subluxation, then it is the Marfan syndrome. ठीक है, everybody has written, seen the images, answered the question of the lens. Anything? Lens we have totally finished. Please see if anything is left for the lens. We have totally finished the lens. If anybody is left with anything, please see. लिख लिया है सबने this area? This also lenticonus. Who had left that? So now put the new heading glaucoma. Now we are going to start with the glaucoma. What is glaucoma, guys? What do you know of glaucoma? What is the necessary thing that we feel like should always be there when we call it as glaucoma? When I am calling it as glaucoma, what is the necessary thing that I will always have? So tell me, what do you know of glaucoma? Increased intraocular pressure, right? So we should always have the raised intraocular pressure, right? And what was the normal intraocular pressure? How much was the normal intraocular pressure? You people are correct. People have the raised intraocular pressure there. And the normal intraocular pressure will be 11 to 21. So glaucoma is the multifactorial. It is a multifactorial optic neuropathy or optic atrophy. ठीक है ना? Optic neuropathy due to the retinal ganglionic cell death. Retinal ganglionic cell death which takes place by the apoptosis. So you have done the patho also, guys. What is apoptosis? It's a optic neuropathy, ganglionic cell death with the apoptosis. An optic nerve cannot regenerate, right? Optic nerve cannot regenerate. Therefore, it will always lead to irreversible diminution of vision. It's a programmed cell death. So whenever there is a cell death, it can take place by the apoptosis or by the necrosis, whenever we have the optic neuropathy, optic nerve will not regenerate. Therefore, it will cause irreversible vision loss. And because optic nerve consists of ganglionic cells, so we have ganglionic cell death, and this ganglionic cell death will take place by the apoptosis. So we have optic neuropathy characterized by the retinal ganglionic cell death by the apoptosis. Retinal ganglionic cell death by the apoptosis. This is the definition of the glaucoma. Then we will write the triad of glaucoma. This consists of the raised intraocular pressure, that is more than 21 mm of mercury. Raised intraocular pressure more than 21 with the optic disc changes and the visual field defects. Raised intraocular pressure more than 21 mm of mercury with optic disc changes and the visual field defects. This is the triad of the glaucoma. And at least 2 out of 3 should be present. Out of these 3, 2 should be present in order to call this condition as glaucoma. If I want to say that this is glaucoma, then out of the 3, at least the 2 changes should be present. Any 2 out of the triad should be present in order to call it as a glaucoma. In order to call it as a glaucoma, 2 out of the 3 should be present. If only raised intraocular pressure is present, if only raised intraocular pressure is present, then it is called as ocular hypertension. Then it is called as ocular hypertension. And if we have the optic disc changes and the visual field defects with the normal IOP, if we have the optic disc changes and we have visual field defects but IOP normal, then it is called as normal tension or the low tension. Normal tension or low tension glaucoma. Then it is called as normal tension or low tension glaucoma. So basically we have got 3 things. One is glaucoma, one is ocular hypertension, and one is normal tension glaucoma. Please see if you have understood this and if you have written. If you have understood and if you have written. And I will show you one question also. ये देखो, क्वेज नंबर 417. And 1024. You can answer the questions also. Which cells are affected in the glaucomatous optic neuropathy? Glaucomatous optic neuropathy mein, it is the ganglionic cell death that you have seen. And which of the following is not a characteristic feature of open angle glaucoma? You can see the D is the out of the triad. D is out of the triad there. Now we are going to talk about the pathophysiology of the glaucoma. Visual field defects cannot take place without the optic disc changes, Benji. ठीक है ना? Visual field defects cannot take place without optic disc changes. So if you go to the pathogenesis of glaucoma, we have three structures. One is the ciliary body, then is the angle of the anterior chamber, and then third is the aqueous outflow system. We have the ciliary body, we have angle of anterior chamber, and the aqueous outflow system. Now this ciliary body consists of two parts. One will be the pars plicata and one is the pars plana. Pars plicata and the pars plana. This is the rough anterior part and this is the smooth and posterior part of the ciliary body, which consists of 70 to 80 ciliary processes. 70 to 80 ciliary processes. Ciliary body में we have pars plicata. Pars plicata में 70 to 80 ciliary processes, which consists of non-pigmented epithelial cells. Non-pigmented kind of epithelial cells, which contains the beta receptors. And these beta receptors will lead to aqueous formation. These will lead to the aqueous formation. So we have the beta receptors, we have non-pigmented, we have 70 to 80 ciliary processes in the pars plicata part of the ciliary body, which is actually responsible for the aqueous formation. Which is responsible for the aqueous formation. So if I give the beta blockers, pharma you people have done or not? Pharma, I think you people have not done, na? Only pharma is left. So when you give the beta blockers, they are inhibiting the beta receptors. They will inhibit the beta receptors and therefore this will decrease the aqueous formation. You can learn the mechanism of action like this. We can understand the mechanism of action for the beta blockers. When you are giving the beta blockers, they inhibit the beta receptors and therefore will decrease the aqueous formation. This aqueous formation takes place by the enzyme carbonic anhydrase. By the enzyme carbonic anhydrase. So if we give the carbonic anhydrase inhibitors, if I give the carbonic anhydrase inhibitors, they will inhibit this enzyme. And therefore, this is also decreasing the aqueous formation. Therefore, it will also decrease the aqueous formation. So, you can understand the mechanism of action of the two drugs. This is the pharma integration with the ophtha. Mechanism of action for the two drugs. Mechanism of action for the two drugs hai. Please see if you have written this much. So after coming from the ciliary body, where will this aqueous humor go? First of all, tell me, have you written this? Ciliary body था, ciliary body से pars pliccata से ciliary processes, नॉन पिगमेंटेड एपिथेलियल सेल्स हैं, बीटा रिसेप्टर्स हैं, एक्वस फॉर्मेशन अलोंग विद द एंजाइम कार्बोनिक एनहाइड्रेज, ये सबने लिख लिया है. नाउ व्हेन इट कम्स आउट फ्रॉम द सीलियरी बॉडी, इट कम्स इनटू द पोस्टीरियर चेम्बर, that is PC. Aqueous humor will come out if you look at the aqueous humor. ठीक है, when it is made from the ciliary body, it will first come in this posterior chamber, then it will come through the pupil in the anterior chamber. Now it will come in the anterior chamber, posterior chamber, then passing through pupil, then anterior chamber, and then it will go to angle of anterior chamber. Now this angle of anterior chamber consists of the 5 structures. This consists of the 5 structures from the root of the iris. Then we have the ciliary body band, scleral spur, then is the trabecular meshwork, and then is the Shalby's line. The angle of anterior chamber, which consists of 5 structures from the root of the iris, ciliary body band, scleral spur, trabecular meshwork, and the Shalby's line. This is also called as iridocorneal angle. This is also called as iridocorneal angle, seen by the gonioscope. Angle of the anterior chamber is seen by the gonioscope. From this angle, now it will go for the aqueous outflow system. It will go to the aqueous outflow systems for the drainage. From this angle of anterior chamber, it will go to the aqueous outflow systems. Aqueous outflow systems, we have two. One is trabecular outflow system and one will be the uveoscleral outflow system. Trabecular के लिए 90% and uveoscleral में only 10%. And ultimately they both are draining into the episcleral veins, into the episcleral space. Aqueous outflow systems, 90% will pass through trabecular meshwork, 10% will pass through uveoscleral, and ultimately they will go into episcleral space. This is the total drainage of aqueous humor from posterior chamber through pupil, anterior chamber, angle of anterior chamber, and drainage. After they are going into the draining systems, after they are going to the aqueous outflow systems, we have two. 90% will pass through trabecular and 10% through uveoscleral. So what will happen if there is a blockade here? Suppose there is a blockade at the trabecular meshwork. Then this will be called as open angle glaucoma. If there is a blockade at the trabecular meshwork, then this glaucoma is called as open angle glaucoma. Example, do you remember? We were having phacolytic glaucoma. So whenever there is some blockade at the level of trabecular meshwork, any kind of cells are blocking the trabecular meshwork, it is the open angle. While the other is angle closure. If there is a closure of this angle of anterior chamber, then this will be called as angle closure glaucoma. Then this glaucoma will be called as the angle closure glaucoma. So one is the angle closure glaucoma and one is the open angle type of glaucoma. Pehle write this, then I will tell you what I am going to say. See, clinically, whenever we say glaucoma, I can have only two types of glaucoma. Either it's open angle or it's angle closure. Angle closure is self-explanatory, which is occurring due to the closure of the angle of anterior chamber, right? So whenever there is a trabecular blockade, then that kind of glaucoma will be called as open angle glaucoma. If it is by inflammatory cells, it is inflammatory glaucoma. Pigmentary cells, pigmentary glaucoma. Lysis of the cortex, phacolytic glaucoma. So anything which is blocking the trabecular meshwork will always cause open angle glaucoma. And if there is a closure of angle of anterior chamber, you cannot see all the structures, and it is angle closure glaucoma. Then it is angle closure glaucoma. Please see if you have understood, if you have written the triad of glaucoma, definition of glaucoma, ocular hypertension, normal tension glaucoma, then drainage of aqueous humor, two kind of aqueous outflow system, angle of anterior chamber, how can you see the angle of anterior chamber, anything that you have not able to write? Anything that you have not written? All right, guys. So here we take a break. This is the last break. After this, we will continue with the glaucoma. And if you have any problem till now in any of the things you are not able to write, not able to understand, then please let me know and we can discuss them. Okay, guys? Welcome back, guys. Please check the audio and the video. Can you hear me? Can you see me? Not done. Those who had not done, they can see, and please tell me which slide to show. I can show you the slide. Anybody who had not done the writing part, I will show you the slide. Please tell me what part you have not done. Kinai, Rishi, Arun, Ghanshyam, Sindhu. You can tell me the slide. The aqueous outflow system, 2 outflows. Then the angle of anterior chamber, whichever slide you people have not done, please let me know. I can show you. Now all done. Have you understood the pathophysiology and drainage from where aqueous humor is forming, then how it is going through angle, and then how it is divided into two parts, 90% by trabecular, 10% by uveoscleral, and ultimately into the episcleral space. That you have understood? सबका यस है? Have you understood that? Okay, so now we will do the types of glaucoma. Like we were having the cataracts, similarly we can have the different kinds of glaucoma. So when I talk about the different kind of the glaucoma, when I have the different types of the glaucoma, one can be the congenital glaucoma and one can be the acquired glaucoma. Congenital and the acquired. And this acquired glaucoma can be divided into primary and the secondary glaucomas. Primary means we have no known cause. If we do not have any known cause of the glaucoma. Secondary means cause is present. If there is no cause of glaucoma, then it is primary glaucoma. If the cause is present, secondary glaucoma. Okay? Now I told you clinically we can have two types of glaucoma. Either open angle glaucoma or the angle closure glaucoma. Similarly, here also we can have the open angle glaucoma and the angle closure glaucoma. So finally, now I can have primary open angle, primary angle closure, secondary open angle and secondary angle closure glaucoma. Primary open angle, primary angle closure, secondary open angle and secondary angle closure with the congenital glaucoma. ये देखो total 5 varieties of glaucoma है. We have congenital glaucoma, primary open angle, primary angle closure, secondary open angle, secondary angle closure. Total 5 varieties of the glaucoma. And out of these, the most common will be this primary open angle type of glaucoma. ये flowchart सबने बना लिया. The primary open angle glaucoma is the most common type of glaucoma. Primary open angle is the most common. Then we will go towards the congenital glaucoma. In the congenital glaucoma, we have raised intraocular pressure less than 3 years of the age. Whenever we have raised intraocular pressure less than 3 years of age, then this will lead to increased size of the eyeball. Then this will lead to increase in the size of the eyeball. which will be called as, write it with the blue color. ठीक है, write it with the blue color. This is called as the ophthalmos. This is called as the ophthalmos due to the low sclera rigidity. In the small children less than 3 years of age, the sclera is very, very soft. So whenever there is a raised intraocular pressure, it can lead to the stretching of the eyeball. This can lead to the stretching of eyeball. This stretching is called as ophthalmos. B for bull-like eyes and B for big size eyes. B for bull-like eyes है, B for big size eyes है. Big क्यों है? Because of the stretching of eyeball due to the raised intraocular pressure, we are having the stretching. B for ophthalmos, B for bull-like eyes, B for big size eyes, B for bilateral, B for boys में it's more common. And this same question, my question was asked in NEET PG 2023 by the same mnemonic and the same name of the patient also. You won't believe कि जो patient का name था, that was also same by which the question was asked. Even the name of the patient was also the same. That was your blue baby boy and Bablu. Blue baby boy and Bablu. Bablu के ही name से the question was asked in NEET PG 2023. Same question आया था, same picture आया था, same name of the patient also Bablu. Blue is the sclera. Here you get blue sclera. Baby means less than 3 years. Boys में it's more common and Bablu is the name of the baby. ठीक है? So always remember blue, baby, boy, Bablu. What will be the clinical features of this Bablu? पहले ये बताओ, इतना लिख लिया. Bull-like eyes, big size eyes, bilateral है, boys है, blue baby boy Bablu है. So this Bablu will come with the typical BPL card. This Bablu will come with BPL card. B for blepharospasm. B for blepharospasm. Now blepharo means the lid. So we are going to have the lid spasm. Then we have P. P for photophobia. The baby will be born with the below poverty line होता है ना, below poverty line card. B for blepharospasm, P for photophobia and L for lacrimation. Lacrimation most common है and photophobia is the earliest. This is the earliest and this is the most common. Blepharospasm, photophobia and the lacrimation will be the triad of the congenital glaucoma. This will be the triad of the congenital glaucoma. We have blepharospasm, we have photophobia and the lacrimation. Then number 2, we can also get the corneal edema. This corneal edema will lead to haziness in the cornea. And this haziness is called as frosted glass appearance. This is called as frosted glass appearance. This frosted glass appearance will be the earliest specific sign that you will get in congenital glaucoma. एक है earliest, एक है earliest specific. We have blepharospasm, we have photophobia, we have lacrimation. Then we have the edematous cornea that will lead to haziness. Now this haziness is called as frosted glass appearance. तो बबलू में ब्लेफरोस्पैज्म होगा, photophobia होगा, lacrimation होगा, along with the hazy cornea. Then number three, we will also have megalocornea. Megalocornea more than 13 mm. Because of the stretching of the eyeball, we will also have the megalocornea along with the Habs stria. Along with the Habs stria, H for Hab and H for horizontal, we are getting the horizontal striations. H for Hab and H for horizontal striations, with B for blue sclera, we will get the blue sclera, as well as B for backward subluxation of the lens. B for backward subluxation of the lens है. Along with this, we will have the optic disc changes. Frosted glass appearance है, Hab stria, horizontal striations you will get, ये भी PYQ है. It can act as a DD of blue sclera, ये हो गया. Megalocornea का DD में भी also you can get this. Along with the subluxation of the lens, backward subluxation of the lens with the optic disc changes. Please write this, and once you have written, then tell me, then I will go with the other signs. Then I am going to do the other signs. Very, very important है बबलू. Let me see if I get a picture of बबलू. ये देखो बबलू picture. These are the Hab stria, colored halos. Then number 8, we will also get the increased size of the eyeball. Increased axial length of the eyeball. Increased is the axial length. Therefore, this baby will have the axial myopia. Normally, if you look at the refractive status of this baby, refractive status कैसा था? Hypermetropia. But here, baby will be having axial myopia with the mild increase in the intraocular pressure. Mild increase है in the intraocular pressure. Why it is mild only? Because the raised intraocular pressure is used in stretching of the eyeball. Because it is used in stretching of the eyeball, therefore it will lead to the raised intraocular pressure. You will get always mild. Though the raised intraocular pressure is giving you so many signs. Blue sclera है, axial myopia है, Hab stria है, megalocornea है. But when you measure it, it's always low because it is used in stretching of the eyeball. Because it is used in the stretching of the eyeball. Now, what is the etiology of this congenital glaucoma? It is due to the congenital malformations. It is due to the congenital malformations. सबने लिख लिया है? In the angle of anterior chamber. So we have a problem in the angle of anterior chamber here. So this will be a angle closure type of glaucoma. Whenever we have glaucoma, either we have a problem in trabecular meshwork or we have the closure in the angle. So here we are having the problems in the angle. So it's a angle closure glaucoma. Therefore, it's a angle closure glaucoma. Now, because its etiology is the malformations and you cannot treat the malformations by drug, therefore, treatment of choice will be surgery here. Therefore, treatment of choice is surgery. What surgery we can do? One, when we can do in clear cornea, and one we can do in the hazy cornea. Clear cornea and the hazy cornea. Clear cornea में we can do the goniotomy, and when we have hazy cornea, there we have to do combined trab plus trab. पहले ये देखो, have you written this? Then I will show you the treatment. Have you written the signs? Everybody has written the signs. We have megalocornea, frosted glass appearance है, blepharospasm, photophobia, lacrimation, frosted glass appearance, megalocornea, blue sclera, backward subluxation of the lens है. सबने लिख लिया है? Congenital malformations वाला. So treatment of choice here is trabeculotomy and trabeculectomy. Trabeculotomy and trabeculectomy. So this will be the opening in the angle of the anterior chamber. We can give the opening in the angle of anterior chamber. Then here we have trabeculotomy, where we will give the opening in the trabecular meshwork, and here we will create a artificial opening or fistula. Fistula we will create between the anterior chamber and the episcleral space. Between the anterior chamber and the episcleral space. So we have goniotomy, trabeculotomy and the trabeculectomy. And the trabeculectomy. Please see if you have written. Then I will show you the picture of Bablu. Please see if you have written. Little upwards. Upwards matlab this one. Please see if you have written. You can see this Bablu was asked in NEET PG 2023 में. This Bablu was asked. And they say that the Bablu is coming with the photophobia and lacrimation. They had asked this question, photophobia, lacrimation they had given. And the remaining things you have to find out from the picture yourself. ये देखो, you can see Bablu है. Bablu is a boy. ठीक है, baby है. That also you can see. What else you can see? You can see the bilateral involvement. Then you can see this blue sclera. Blue sclera भी visible है. And then you can see hazy cornea. So all these things will help you to make the diagnosis of buphthalmos. Buphthalmos or congenital glaucoma. Blepharospasm है, photophobia, lacrimation है, blue sclera है, bilateral है, boys है, hazy cornea है. That means it is buphthalmos. No iris is seen. No iris is seen, therefore I can say that this is hazy cornea. If no iris is seen, then this is hazy cornea. Have you seen this picture? Then I will show you the half stria also. ये देखो. Half stria में you can see the horizontal striations. You can see these horizontal striations. These are the half stria. Horizontal striations are the half stria which are found in the congenital glaucoma or the ophthalmos. In the congenital glaucoma or the ophthalmos. सबको समझ में आ गया पिक्चर? Now we will do the open angle glaucoma. Now we will try to do this open angle glaucoma and we will see how trabecular blockade can cause the glaucoma. ठीक है? Now we will try to understand how the trabecular blockade can cause glaucoma. See ये देखो, I am trying to explain you from the picture. This is your ciliary body from which this aqueous humor will come in this posterior chamber. Then ये pupil है and pupil के through this aqueous humor will come in anterior chamber. ठीक है? Anterior chamber से then it will go to this angle and angle के बाद 90% is passing through this trabecular meshwork. 90%. ठीक है? Now, if there is a blockade at the level of this trabecular meshwork, what will happen? Now, this aqueous humor will go back. Okay? Now, it is going back, and when it's going back, it will go into the vitreous cavity. From here, it will go into posterior segment. Now, when the aqueous humor starts coming in this vitreous cavity, it starts coming in this vitreous cavity. It is affecting the outer rim of the retina. Outer rim मतलब periphery of the retina. And periphery में we have rods. We have rods. Center में we were having the cones. And periphery में we have rods. And rods help in night. Therefore, this patient can come with the night blindness. Don't write it. I will write it for you. I am just explaining you. First try to understand. Okay? This I will write again. So in this way, it is affecting the outer rim of the retina, the periphery of the retina. Therefore, rods are affected. Therefore, we can have the night blindness. And एक चीज और होगी, there is a peripheral constriction of visual field. जो हम देखते हैं, or the area all around us is our visual field. One is central, one is peripheral. So if there is a peripheral retina which is affected, there is a peripheral constriction of visual field. So now only central area is visible. This central type of vision will be called as the tunnel vision. ये देखो, if I show you, टनल विजन का दिखाती हूँ एक. This central kind of vision is called as the tunnel vision. For example, what will happen? Only the central area will be seen and the peripheral area will be gone. See this picture. If you see this picture, tunnel vision की बड़ी beautiful picture लगती है मुझे ये. First वाले में full of the bullock is seen and second वाले में only face part is seen because all of the peripheral vision is gone. This is called as tunnel vision, which will be found in primary open angle glaucoma. This will be found in the primary open angle type of glaucoma. Are you getting this? So now we will write it for you. If I say that the patient is having the primary open angle type of glaucoma, it is also called as the chronic simple glaucoma. It is also called as the chronic simple glaucoma. Primary open angle glaucoma is also called as chronic simple glaucoma. Primary, I told you, when we have no known cause. Whenever we do not have any known cause. And open angle glaucoma means we have trabecular block. है ना? Whenever we have the trabecular blockade, it will lead to open angle glaucoma. So no known cause for the trabecular blockade is the primary open angle glaucoma. With the chronic, if it is chronic, we will have gradual diminution of vision. Simple means no congestion. Here we are not having any congestion and therefore it is painless condition. And when I am saying glaucoma, that means the triad should be present. At least 2 out of 3 parts should be present. So this is the full definition of primary open angle glaucoma, and even from the name itself you can find out what type of condition we are having. Primary means no known cause, open angle glaucoma है, trabecular blockade है, chronic means gradual diminution of vision है, simple means painless condition है. And if you remember, I told you that whenever we have gradual, painless, progressive diminution of vision, 2 important DD थे. One was cataract and one was open angle glaucoma. Have you understood this from definition? Definition से याद रहेगा. What is the primary open angle glaucoma now? Can we see the risk factors now? Risk factors of the primary open angle glaucoma. Number 1, we can have hereditary. Hereditary हो सकता है. We have 2 genes. One is the optineurin and one will be the myocilin. Optineurin and the myocilin. The 2 genes, optineurin and myocilin, are located on chromosome number 1. उसके अलावा we have diabetes, we have hypertension, we can have myopia, we can have smoking. All these are the risk factors of open angle type of glaucoma. All these are the risk factors. We can have the hereditary factors, and the glaucoma can run in the families. It is more commonly associated with diabetes, hypertension, myopia, smoking, all these things, with age more than 60 years and equal in males and females. So just like cataract, whenever we have a male or a female more than 60 years of age with the family history, with diabetes, with hypertension, with smoking or with myopia, all these are the risk factors for open angle type of glaucoma. Now what can be the symptoms of these patients? Symptoms. For the symptoms, the most common is the frequent change of reading glasses. Frequent change in the power of the reading glasses. देखो कैटरैक्ट में frequently there was a change in the power of distant glasses. ठीक है. डायबिटीज में fluctuation of the refractive error था. Third is your glaucoma. Glaucoma में we have a change in the power of reading glasses. ऐसा क्यों है? Because here we are having raised intraocular pressure, which can affect the ciliary muscle. Ciliary muscle, and ciliary muscle helps in accommodation. This will affect the accommodation, and accommodation will affect the reading or near vision. That is why this patient will have frequently the change in the power of the reading glasses. Therefore, here we are having again and again change in the power of reading glasses of the patient. Then number 2, we will have the atrophy of the peripheral retina. So this raised intraocular pressure will affect the peripheral retina, There is a atrophy of peripheral retina, and periphery mein we have rods. Therefore, this patient can also present with the night blindness. Can you tell me which cataract was also presenting with night blindness? This is one more cause for the night blindness. One more cause है night blindness का. We can have the DD of night blindness here. One, patient can present with the frequent change in the reading glasses, and second, patient can also present with the night blindness. Then number 3, there is a peripheral constriction. We can also have peripheral constriction of the visual field. Cortical तो है, cortical का which cortical was presenting with night blindness? Which cortical? Peripheral constriction of visual field. Therefore, the patient can also present with the tunnel vision. Therefore, the patient can also present as a DD of tunnel vision. तो इन सब DDs की आप एक लिस्ट बना सकते हो. द नाइट ब्लाइंडनेस, देन डे ब्लाइंडनेस है, ल्यूकोकोरिया, कलर्ड हेलोज है, सेकेंड साइट है, टनल विजन है, एंड वेन एवर यू विल गेट द अदर कॉज यू कैन एड इट टू इट. ठीक है, तो सारी की सारी लिस्ट बन जाएगी. यस, इट वॉज अ क्यूनिफॉर्म टाइप ऑफ कॉर्टिकल कैटरेक्ट. एंड देन नंबर 4, द टाइप ऑफ विजन हो जाएगा ग्रेजुअल पेनलेस प्रोग्रेसिव डिमिनिशन ऑफ विजन. सो देर आर सो मेनी सिम्टम्स ऑफ दिस पेशेंट. सिम्टम्स समझ में आ गए सबको? प्लीज सी द सिम्टम्स. हैव यू अंडरस्टूड? Symptoms of this open angle glaucoma, have you understood? Can we go to the signs now? Signs में you will get a triad in the open angle glaucoma. What was the triad? First was the raised intraocular pressure. First you will get raised intraocular pressure more than 21 mm of mercury. Whenever the pressure is more than 21 mm of mercury, then it is the raised intraocular pressure, which you can measure by tonometer. Fourth point क्या है? Gradual, painless, progressive. Gradual है, painless है, as well as progressive. Gradual, painless, progressive diminution of vision. So this another instrument is tonometer. Today you have read about keratometer, biometer, A-scan, gonioscope, and this is the tonometer. The most commonly used tonometer is the Schiot's indentation tonometer. The most commonly used tonometer is the Schiot's indentation tonometer, while the gold standard tonometer will be gold for gold, Goldman's applanation tonometer. Goldman's applanation tonometer. One is the indentation tonometer, one is applanation tonometer, and one is most common and one is gold standard. Schiot's tonometer and the Goldman's applanation tonometer. This is the first part of the triad. The first part of the triad. The principle of this tonometer will be the Imbert-Fick law. The principle of this tonometer is Imbert-Fick law. Then the second is the optic disc changes. Now, in order to understand the optic disc changes, first of all, we will understand what is a optic disc. We have to understand what is the optic disc. So, we will first make the eyeball. Like this. And we can divide this into the two parts. One is the nasal retina. And one is the temporal retina. Nasal retina will continue as the optic nerve. Now, if you look at the front portion of this will be the optic disc. This front portion is actually the optic disc hai. And the central area is the cup or the hollow of the optic disc. Now, this hollow means there is no fiber. We do not have any fiber of optic disc. Therefore, this will lead to the blind spot. Therefore, it will lead to the blind spot. And you know, the visual field affected, physiology to ho gaya hai na, physiology, you know, the visual field affected is always diagonally opposite. Kyunki it is coming from nasal retina. So, this is found in the temporal visual field. Therefore, it will come in the temporal visual field. पहले ये देखो, ये बात समझ में आई. ऑप्टिक डिस्क था, ऑप्टिक डिस्क, this was your optic disc which will have a central hollow hoga, central hollow like this. So we will have a disc and we have this cup, okay, and this periphery is called as the neuroretinal rim. So what happens that the nerve fiber layer of the retina will continue as the optic nerve. भी एक चीज दिखाती हूँ, just wait. What I'm trying to say, suppose this is the hand is the retina, ठीक है? Now this is continuing as the optic nerve. So the front portion will be seen like this, the optic disc. So this portion will be hollow. Hollow hai where we do not have any optic nerve fiber. Because we are not having any optic nerve fiber, so if any rays fall on this area, we will not have any image, blind spot. Therefore, we have blind spot due to this. So we all have a physiological blind spot due to this hollow. And this blind spot lies in which field? Because optic disc is a nasal retina. Therefore, the blind spot lies in the temporal visual field. Therefore, it lies in the temporal visual field. Are you getting this now? Therefore, it lies in the temporal visual field. Therefore, it lies in the temporal visual field. So, this is a disc, this is a cup, and this is a neuroretinal rim. And the normal CD ratio will be equal to normal, यहाँ पे लिखती हूँ, normal CD ratio. That is the diameter of the cup upon the diameter of the disc. Diameter of the cup upon diameter of the disc is equal to 0.3 or 0.4. So if I divide the whole of the optic disc, suppose ये optic disc है and this is the cup portion, ठीक है. So if I am dividing this whole of the optic disc into 10 parts, 1 है, 2, 3, 4, 5, 6, 7, 8, 9 and 10. So this is occupying 1, 2, 3 and 4. So either 3 on 10 or it is 4 on 10. Therefore CD ratio हो गया 0.3 और 0.4. CD ratio समझ में आया? What is CD ratio? Why we have blind spot? 0.3 or 0.4. This also you have understood? Have you understood this? सबको आ गया? Good है. Now what are the changes? First we will have increased size of the cup. This will be called as cupping. Slowly and gradually we will have more and more loss of the optic nerve fibers. Optic nerve fibers loss होंगे, so this is called as cupping. Why there is a blind spot? Jav, why we have a blind spot? Due to this cup, which is a hollow portion of the optic nerve, no fibers, because here we do not have any optic nerve fibers. So if any ray will fall on this, no image formation. In this area, no image will be formed. Therefore, it's a blind spot. ठीक है Jeff? And slowly and gradually, the size of the cup will go on increasing like this. When the cup will increase, this neuroretinal rim will decrease. So we will have increased size of cup and we will have thinning of the neuroretinal rim. Like cupping में 0.5 है, 0.6, 0.7, 0.8, 0.9 and total. This kind of cupping we will have. This is the cupping. And then we also have thinning of the neuroretinal rim. Increase size of the cup hai, and then we have thinning of neuroretinal rim. Along with this, we have vertically oval cupping. The shape of the cupping is vertically oval due to the early loss of the superior and the inferior fibers. Due to the early loss of superior and the inferior fibers, we will have the vertically oval cupping due to the early loss of superior as well as inferior fibers. Means suppose this was the optic disc and this was the cup. Now we have first loss of this fibers and this fiber, superior and inferior. Therefore the shape of the cup will be vertically oval like this. Shape of the cup हो गया vertically oval. Along with the splinter hemorrhages over the optic disc. So you can get the small hemorrhages over the optic disc like this. These are called as the splinter hemorrhages over the optic disc. Along with the splinter hemorrhages over the optic disc like this. Splinter hemorrhages हैं over the optic disc. 1, 2, 3, 4 देख लो. Yes, these are the pinpoint hemorrhages. These are actually pinpoint hemorrhages hai. Then number 5, we will also get the laminar dot sign at the lamina cribrosa. We will also get the laminar dot sign at the lamina cribrosa. Now, what is this lamina cribrosa? If this is the sclera, so the part of the sclera through which the optic nerve fibers are coming out, this is the retina here. The part of the sclera through which the optic nerve is emerging out. Hemorrhages are due to the raised intracranial pressure, this will be due to the raised intraocular pressure. We will have the leaking from the capillaries, bleed hoga. Now this part of the sclera through which the optic nerve fibers are coming out like this. The optic nerve fibers are coming out. How many fibers are present in one optic nerve, guys? Optic nerve में how many fibers? Physiology you have done. चलो बताओ. How many fibers are present in one optic nerve? 100, 1000, 10,000, million, billion. कितने fibers होते हैं एक optic nerve में? This is the lamina cribrosa है. So when you see the cut section of this lamina cribrosa, how many fibers are present in one optic nerve? We have actually 1 million fibers. Approximately 1 million hai. So 1 million fibers are passing through sclera. So you have 1 million holes in the sclera. 1 million holes hai. Therefore, we have the 1 million holes in the sclera like this. This is the normal lamina cribrosa hai, where pores are not visible. Where the pores are not visible. In the normal lamina cribrosa, pores are not visible. But when we have the raised intraocular pressure, these pores are distended like this. When we have the high intraocular pressure. ठीक है? So these pores are distended and visible. Normally they were not visible. When there is a high intraocular pressure, these are visible. This is called as laminar dot sign. Laminar dot sign देख लो. Have you understood? Number 5 पे है laminar dot sign. This is called as laminar dot sign. This is called as laminar dot sign. Everybody has understood? Number 6 पे चले. We will have bending of the temporal vessels. We will also have the bending of temporal vessels towards the nasal side. This will be called as nasal shifting of blood vessels. There is a bending of the vessels from the temporal side to the nasal side. If this is a optic disc है, ये vertically oval cupping है, and we have the vessels here. So central retinal artery है, which divides into 4 end arteries, 2 on the nasal side and 2 on the temporal side है, like this. So we have supronasal है, infronasal, suprotemporal, infrotemporal. तो अभी क्या है? We are having bending. Suprotemporal will bend towards supronasal, and infratemporal will bend towards intranasal. This is called as nasal shifting of blood vessels. This will be called as nasal shifting of blood vessels. Number 6 होता है bending of the temporal vessels towards the nasal side is called as nasal shifting of blood vessels. Is called as nasal shifting of the blood vessels. And this bending will be called as, this bending is called as double bending or Z bending, double bending or Z bending, or the bio-netting sign. This bending is also called as the double bending है, Z bending है, or the bio-netting sign. तो nasal shifting of blood vessels को we can also call it as double bending, Z bending, or the bio-netting sign, because how they are bending, they are going backward like this. This is also going backward like this. Then it's going and again bending, going and again bending. तो we have double bending है, 2 times bending है, Z bending है, और the bio-netting sign. Or we have the bio-netting sign. Double bending, Z bending, or the bio-netting sign. And finally, we have the total cavernous, that is cave-like, total cave-like optic atrophy. Total cave-like optic atrophy, which is also called as cavernous optic atrophy. So please see if you have any problem in any of these. If you have any doubt in any of these optic disc changes, starting से cupping है, thinning of neuroretinal rim है, hemorrhages है, vertically oval cupping, laminar dot sign, nasal shifting of blood vessels with the double bending, Z bending, with the total cavernous optic atrophy. With the cave-like optic atrophy, total cavernous optic atrophy है. Imaduddin, which slide? This bending of the blood vessels इस तरह से bend हो रहा है, then it is going behind this optic disc and again it is bending. नीचे again this is bending like this behind, then it is going behind and again it is bending. So from the supratemporal coming supranasal, from infratemporal it is coming infranasal. This is called as double bending, Z bending, or the bio-netting sign. This is called as Z bending, double bending, or the bio-netting sign. Can I see the 5th point? Okay, this is your 5th point. डॉक्टर लक्ष्मण हो क्या? लक्ष्मण? So we have done 2 parts of the triad. One is your raised intraocular pressure, then second is the optic disc changes है. Second is the optic disc changes. Written everyone? चले अब थर्ड पर. लाखोन. चलो तो going to the third part of the triad, the visual field effects. Visual field effects है. So visual field we take in degrees. How many degrees one can see, or it is also called as the isopters. Whenever I measure the visual field of any patient, so I will measure in degrees or isopters. Like if I see the normal visual field, then this is equal to the S nit. Normal visual field है. Class is till 6 p.m. Today I am going to stop at 6 p.m. Because 6:40 पे तो we have the Rosa Iftar, so we cannot do 7 or 8. It is as nit. So minimum is superior, then is nasal, then is inferior, and then is the temporal. ये देखो, minimum is 50 degree, then 60 degree, then 70 degree, and then 90 or 100 degree. So whenever we say minimum, minimum is superior. Minimum I can see on superior side, followed by inferior, followed by the nasal, followed by inferior, and maximum होता है temporal पे. Now why it is so? Because when I look upward, we have this brow bone. So there is a limitation. Nasally we have nose. Inferiorly we have this cheekbone. So temporally it's maximum that I can see. Temporal visual field is maximum. Now if I look at the visual field, I can divide this visual field into the two parts. One is the central and one is the peripheral visual field. Central will be from 0 to 30 degree and peripheral is beyond the 30 degree. Central visual field is seen by the campimeter. Campimeter है, and peripheral visual field by the perimeter. तो ये हो गया C for center and C for campimeter, P for peri-peri. Peri के लिए peripheral, peripheral के लिए perimeter. तो बायोमीटर था, केरेटोमीटर था, टोनोमीटर था, पेरीमीटर था, as well as campimeter. Visual field can be of two types: central visual field, peripheral visual field. Central visual field is seen by campimeter, peripheral visual field is seen by perimeter. Then we have the retina के fibers. रेटिना के फाइबर्स हैं. रेटिना के फाइबर्स we can divide into temporal fibers and the nasal fibers. Temporal fibers are the arcuate fibers. These are arc-like. Arcuate fibers हैं. And this is most sensitive. They are most sensitive to the glaucoma. The fibers which are most sensitive to the changes of the glaucoma are the arc-like fibers or the temporal fibers which are most sensitive. This is also called as the Jerum's area. The fibers which are more sensitive to the changes of glaucoma are the temporal fibers, and this area is also called as the Jerum's area. This area is also called as the Jerum's area. Is also called as the Jerum's area. Now, because temporal fibers are more sensitive, so which visual field will be more sensitive? Nasal field. So, if I divide the visual field into four parts, superior, inferior, nasal, temporal. So, what is the order? First will be superior and inferior, they will go, because we were having the vertically oval cupping like this. So, first to go is superior, inferior. Then is the nasal because of the temporal fibers. Therefore, this temporal is last to go. Therefore, which visual field will be last to go? Visual field which is last to go is the temporal visual field. This is also a PYQ. Which visual field is last to go? Is the temporal visual field. So if you see the visual field effects order, इसके लिए we have a mnemonic in corona. BP should be doubly. In corona, BP should be doubly tested. So in corona means we will have the isopter contraction. First is isopter contraction, then B for bearing. Next होता है bearing of the blind spot. This is the order of visual field effects. Then P is the paracentral scotoma. Then Siddle scotoma. Which will be sickle cell shape. Then we have the Jerum's scotoma or the Arcuate scotoma. Jerum's scotoma or the Arcuate scotoma. Then we have double arcuate scotoma. And then we have the tunnel vision. And finally, temporal visual field. Temporal visual field is last to go. So first you write, then I will tell you the diagram also. First is this in corona, that is isopter contraction hoga. Then B for bearing of blind spot, P for paracentral, S for Siddles, BE से Jerum's scotoma, W से double arcuate, and then we have 2 times T. This is the total order. Paracentral scotoma is the earliest significant scotoma. This is the earliest significant scotoma because these two are not significant. because these two scotomas are not significant. And temporal visual field is last to go. This is a PYQ. This is earliest significant hai. This is the earliest significant. This is the arcuate scotoma. Please write, everybody please write and then tell me, then I will draw the diagram. Have you written, guys? When you have written, tell me, then I will draw the diagram. What about others? What about the other people? So what you are going to do, you have to draw a large oval. First, we will draw a large oval. And then I'm going to draw a circle inside it. This is the visual field. So you can see this will be the total field. These are called as the isopters, up to which the patient can see. And here you can see the central field. Central visual field hai. This will be 0 degree and this is the 30 degree. And inside this we are going to have the blind spot यहाँ पर. Now because we are drawing the blind spot on this side, therefore this will be the temporal visual field and ये हो गया nasal visual field. First draw this much. The total isopters है, central visual field है from 0 to 30 degree along with the blind spot. ये हो गया blind spot. And blind spot will be towards the temporal visual field. Blind spot is towards the temporal visual field. Now what was the first thing? Isopter contraction. So you can draw the contraction of the isopters. Visual field is getting less and less. This is the constriction of the peripheral visual field. This is number 1. Isopter contraction. This is the earliest isopter contraction. Similarly, we have constriction of the central field also. We have a constriction of central visual field like this, where we will leave the blind spot out. So we are leaving this blind spot out. This will be called as number 2, bearing. Bearing of the blind spot. This is called as bearing of blind spot. One is the isopter contraction and one is the bearing of the blind spot. And both of them are not significant. Both of them are not significant. So which one is significant then? A new scotoma. Here is the significant scotoma. This is the number 3, that is paracentral. This is the paracentral scotoma. This is the first scotoma which is significant. And then it combines with the blind spot like this. So it makes a large scotoma now. This larger scotoma will be the number 4, the sickle scotoma. Sickle cell shape. Sickle cell shape scotoma or the sickle scotoma. ये है paracentral scotoma. This is the sickle scotoma. Paracentral scotoma and the sickle scotoma. Then next होता है arcuate scotoma. Arcuate scotoma will be arc-like होगा because it is going in the temporal fibers. Temporal fibers होते हैं arc-like. So we are having a arc-like scotoma like this. ये देखो. This is the arc-like scotoma. This is number 5. Called as the number 5 is the arcuate scotoma, or it is also called as the Jerem scotoma. Arcuate scotoma or the Jerem scotoma. Similarly, the arcuate scotoma can be formed on the other side also. So here we are having one more arcuate scotoma like this. This will be called as number 6, double arcuate. This is called as double arcuate scotoma. We have arcuate scotoma and we have the double arcuate scotoma. And the vision which is left in the center, ये वाली, this will be number 7. Number 7 हो जाएगा tunnel vision. And number 8, this temporal field will be the last to go. Therefore, temporal visual field is last to go. Please draw everyone. Therefore, temporal visual field is the last to go. Then I will show you the diagrams. Please see if you have drawn. Everybody has drawn, has written, understood. That is how the temporal visual field is the last to go. लिख लिया है सबने? Everybody has written this or not? So if you have written, then you can see this is the Schwartz tonometer. Schwartz indentation tonometer है. This is the Schwartz indentation tonometer, while this one is the Goldman's tonometer. Goldman's tonometer ka, this is just the probe portion, the probe of the Goldman's tonometer. This is the probe of the Goldman's applanation tonometer. This is only the probe portion of the Goldman's applanation tonometer, while the full tonometer is like this. So this area is the probe. Full is the Goldman's applanation tonometer, and this is the probe of the Goldman's applanation tonometer. This is the probe of the Goldman's applanation tonometer. While any other picture? Yeah, that's so this is about the visual field effect. You can see the triad of open angle glaucoma, very very important hai. Triad of open angle glaucoma. Then I can share you the these are the lens images, and these are the glaucoma images. Lens images and glaucoma images. So today we are going to stop here. Tomorrow we will study about the treatment of open angle glaucoma, because I have to describe everything starting from anti-glaucoma drugs, laser treatment and the surgical treatment. So I'm going to stop here so that you can revise everything today, and tomorrow we will start with the treatment of glaucoma along with the retina and the neuro-ophtha. So I have to maintain a balance so that you keep on studying every day and you are understanding also. The goal is not just to finish the course. You have to understand the things also. So tomorrow we are going to finish this glaucoma. Then we will do retina, and we will do neuro-ophtha. Day after tomorrow we will do the squint, optics, then uveitis, cornea conjunctiva, and adnexa. This is how I usually divide the topics. And tomorrow class timings again, we are going to start from the 10 o'clock, and we will be finishing the topics as the time will take to finish the topics. We will the class. Okay, so it will be according to the topics. There is no hard and fast rule. I will have to finish this. What is bearing of blind spot? So can you see here we are having a invert turn. It is taking this invert turn. So when there is a constriction of the central visual field, it takes an invert curve around this blind spot. So this invert curve around the blind spot and leaving the blind spot out of the central field. When it is leaving the blind spot out of the central field, then this is called as bearing, or you can call it as sparing also. Bearing or the sparing of the blind spot, that is called as bearing or the sparing of the blind spot. Are you getting, Jeff? Any other question anybody wants to ask from the anatomy, development, visual acuity, lens and glaucoma? Then you can ask anything. I have already forwarded you the images of the lens and glaucoma so that you don't have any fuss. Then I have shared so many questions related to the topics that we have done today. These are high-yield PYQs which you compulsory should know. So you can revise these topics, you can read these topics, you can attempt to the questions, and if you have any doubt, you can post it on the group and we will discuss it. Okay. So thank you so much, guys. Take care, and Eid Mubarak to everyone in advance. Those who are having Eid tomorrow, and Eid Mubarak to everyone, those who are having the Eid today. And I hope you have understood the things. You will try to read them, and you will have a better view, है ना? We will have the clear 10 on 10 performance in Ophthalm. So take care, guys. Bye bye.